Good afternoon, good evening. Thank you so much for joining us for the weekly briefing on health emergencies across Africa, brought to you by Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. Today, we are joined by His Excellency Dr. John Kaseya, the Director General of Africa CDC, who will be providing the situation analysis across the continent. We are also joined by other colleagues that will be as well intervening through the session. I will now hand it over to Dr. Kaseya to start the session. Over to you, DG.
Thank you so much, Margaret. Good morning, good afternoon, good evening. Greetings from Copenhagen, where I landed yesterday night. And we started some meetings this morning, and I will debrief you. Today, our presentation will not just be focused on outbreaks, but will brief you on a number of issues, especially the context of health financing in Africa, because that issue is critical for our outbreak response. And I think we'll allow more time, not only 1 hour maybe. I will request Director Margaret to give maybe till 3:30 my time for questions, because the presentation will be a little bit long. Let us start with our slides. Thank you. For those who know Africa CDC, and you are very welcome to visit us. This is the building of Africa CDC. Let's move. I wanted to share with you some of the discussions we started to have with our member states and our leaders. You know, we are all familiar that from 2022 to 2024, there is a huge increase of outbreaks. This is the first time we can see an increase of more than 41% in 2 years. And if you see the trend in 2025, we are not so optimistic that 2025 can be better than 2024. We know also our continent is facing a number of other challenges, like the insecurity in the eastern part of the DRC, like what's happening in the western part of the continent. And that context is in addition to the decline of ODA. We started to discuss that. We are losing almost 70% of our official development assistance. And we are also facing a number of issues in terms of debt servicing and dependence on imported medical countermeasures. Combining the two situations, Africa is facing a major risk. Based on the estimate from Africa CDC, we believe that 2 to 4 million annual deaths will be in addition to what we have today. We are also expecting to see 39 million people moving into poverty, additional 39 million people. And this figure is showing clearly that Africa will face what we call the reverse of the 2 decades of health achievement that we had in various areas of public health. And the worst one, the occurrence of an African-made pandemic. This is what is making us awake in Africa CDC on a daily basis, because we don't want to be accused of making the planet at risk. But this is the context. We are talking about it for a very long time. And today we want again to talk about it. Next slide, please. What did we do? Our role is not just to alert. Our role as Africa CDC is to take appropriate action. On the 13th of February, I called all ministers of health. You see the photo of all of them. 45 ministers attended. Others were represented by deputy ministers or permanent secretary. And during this meeting, we discussed the health challenges vis-à-vis the health financing issue. And we drafted some solutions. Next slide. These solutions were based on what we are sharing with you, the two slides. The first one, we analyzed how many countries they achieved the Abuja target of 15%. We saw maybe 2 countries, Rwanda and Botswana, but others, they are lacking beyond. And this is a major commitment from our leaders that we are not fulfilling. Next slide. And we wanted to know why we are not fulfilling that. It's because only 16 countries out of 55 that we have in Africa have the National Health Financing Plan in place. It means if you don't have a National Health Financing Plan, how can you advocate to get more funding from your government? How can you advocate to get appropriate funding from private sector and other sources? Knowing that, next slide, we decided to bring to our leaders on the 14th of February, it means one day after the meeting we had with ministers, this issue of health financing. But we consulted also the governing board of Africa CDC, the Committee of Head of State of Africa CDC, and we had this meeting led by President Kagame, who is our champion on domestic resources, bringing some head of state together to think about how can we reverse the trend of health financing and domestic resources in Africa. This meeting, next slide, led for a number of decisions. But before making sure that these decisions can be implemented and supported, immediately after the AU Assembly, I flew to Washington. I met World Bank, the 2 senior vice presidents of World Bank. I met the private sector. I met people in the Center for Strategic and International Study. It means CSIS. That was a bipartisan meeting bringing Republicans and Democrats to discuss with them what Africa was suggesting as solution. Next slide, please. And then, after discussing with them, last Friday, I met in my office the president of Angola, who is the chairperson of African Union. I met also the chair of African Union Commission, His Excellency Ahmad, who came to discuss all of these solutions with us. Immediately after them, I had the opportunity to meet the Prime Minister of Ethiopia, His Excellency Abiy. All of these leaders, they clearly told us that solutions that Africa CDC was pushing, in addition to the commitment we are receiving from our key partners to support these solutions, were the best way to move forward with the agenda of more health financing for Africa. The same day, the same Friday, next slide, I had a meeting with ministers and with the WHO regional director to discuss these solutions. What are the solutions? We are talking about the 3 pillars. The first pillar is how to enhance more domestic financing, but that must be aligned to the National Health Financing Plan and to advocate for what we call a transitional plan with our external partners. For this first pillar, you will see how we'll implement that. Because that one is the critical one. Without the first pillar, we cannot move to other pillars. The second pillar is the innovative financing, how to have more funding for Africa CDC, because we need $2 billion per year to support outbreak response in Africa. But this $2 billion, we cannot get that from voluntary contributions of our member states, knowing that the fiscal space is too tight. The third pillar is how to get more blended finance. We need more investment in a number of areas. These are the three key pillars validated by African ministers, validated by African head of state, supported by World Bank and a number of partners. And we need now to start to implement that. Next slide. This one is just to show to you what we are calling the first pillar. It means we need to have costed strategic plan and national health financing plan. We need to push for more alignment of external resources. This is what we call the Lusaka agenda. And we need, and this is what we are doing now, to talk with our partners how they can invest wisely the resources to leverage on domestic resources and to make the impact. The next slide, please. Regarding the second pillar, African leaders, they accept now to move on with what we call the innovative financing mechanism. How to use our diaspora, because we know they are contributing around $95 billion in Africa per year. How can we capture some of this fund for the health sector? How can we have some of the taxes in place? They gave us the green light to start to see how to implement that. And this is a major success story for Africa. Next slide. And this one, we are talking about more investment through private sector, bringing the blended finance mechanism. We need the concessional funds that can unlock and de-risk investment from private sector, mostly in local manufacturing, electrification of health centers, connectivity, and the digital health. And the last one is the supply chain infrastructures. Next slide. We even discussed with them a kind of roadmap. And this is the roadmap that we are implementing. And we agreed to put in place a committee that will represent all ministers and a number of partners. And the members of this committee will even attend with us the spring meeting in Washington in April to discuss with all African ministers of finance and key partners like World Bank, IMF, on how we can accelerate the implementation of all of these solutions. Next slide. I debriefed last Friday all ministers. We had 45 ministers who attended the meeting, 8 deputy ministers, and others. In addition, we had Dr. Chikwe and the new commissioner who replaced my sister Minata, who's Her Excellency Amma from Ghana. All of them, they attended this meeting. And everything I'm sharing with you was approved by the ministers. This meeting was led by the Minister of Zambia, who is the chairperson of the governing board of Africa CDC. It means we have the highest political buy-in from our head of state. We have the strategic buy-in from our ministers and partners. We have the technical knowledge how to put it in place. We are putting in place the committee, and we are accelerating the process. Next slide. This week, I started this trip. Monday, I was in Sweden. I met senior officials from the government of Sweden. I had also opportunity to meet European CDC. Tuesday night, I was in Norway to have a meeting with Norway and all colleagues, all officials from Norway and partners. We even signed with the Minister of Health on behalf of the Minister of Foreign Affairs a comprehensive MOU linking Norway to Africa CDC. And today I landed to Denmark. I started my morning with Bavarian Nordic, and the agreement is we finalized all discussions in 2025. Mpox vaccine will be now manufactured in Africa. On Saturday, I'm flying back to DC. I will be in Washington and in New York for the week. And we have some meetings with some senior officials, and we hope that they will support the plan that we have in place. Next slide, please. Let us come back quickly on our diseases after briefing all of us esteemed journalists on the health financing issue on more concrete way Africa CDC is tackling this issue. Regarding Mpox, it's still a major public health emergency in Africa. And you will see from January to date, we already have more than 30,000 cases and more than 300 deaths. It's a lot. We are still losing so many people due to this outbreak. And you'll see there is a new mutation of the virus. People can say confirmed cases are decreased. I will not say it decreased. I will say the testing coverage is low due to the issue we already discussed. But you'll see more countries are affected, like Uganda, like Tanzania. But let us discuss some cases. Next slide. If we go to Tanzania, officially, this is the first time Tanzania is reporting Mpox outbreak. In total, we have 55 suspected cases. We have a testing coverage of 82%, and we had 22 confirmed cases. We are still glad that we don't have people who are passed on due to Mpox in Tanzania. But we are following the situation because we have more than 122 contacts that we are following. And we hope to continue to support Tanzania, not to lose people due to this outbreak. Next slide. DRC is a major concern. I was talking about the mutation of clade 1A, apobacteri. I don't like mutation of virus. We all know what happened with COVID. We all know what happened with clade 1B in the eastern part of DRC. This is what is making me shaking every time when I think about what could be next. In 2 years, 2023, 2024, we have 2 mutations of Mpox virus. What will be next? I don't know. But DRC is where we see also a decline in terms of testing coverage due to what's happening in the eastern part of DRC. I support the statement made by His Excellency, the Chairperson of African Union Commission, congratulating Qatar, putting together President Kagame and President Tshisekedi. We need to stop this war. We are saying that loudly. For the past 2-3 months, we are saying that. I wrote to African head of state, we need to stop that. Next slide. The challenge regarding the testing, we already discussed that, and we know, you can see how so many regions are not doing well just because of insecurity, because of transportation of samples. And Africa CDC cannot create magical solutions if we don't have these basics in place. This is why we need to have peace and we need to have infrastructures that can help us to do our job. Next slide. Next slide, please. It seems we are stuck with the slides. Addis, is it issues?
On my side, Excellency, it's on vaccine delivery.
Okay, now I can see that. I wanted quickly to update our colleagues that we are providing vaccines to all countries in need. Currently, we have 8 countries who receive vaccines and we have ongoing campaign. Want to share with you that more than 544,000 people were already vaccinated, and this is a great success. It means we used around 1 million doses of vaccine. Next slide, please. But there is a but. You'll see in DRC, we start to face a challenge. The challenge because vaccines, they were supported by partners for all taxes and import costs. Currently, it was requested to Africa CDC to pay that, and we went to the government. My team is talking with the government of DRC. I will talk with the minister. We hope, based on the commitment we got, that DRC will release the document today or tomorrow for us to get access to vaccine. Let us make it clear. There is no shortage of vaccine. There is administrative issues in DRC that is not allowing vaccine to land there and to continue the vaccination campaign in Kinshasa and other provinces. Next slide. It's important to know, based on the meeting I had with Bavarian Nordic today, for local manufacturing to be a reality, we need the demand side, and this demand is based on the volume. Today, we are glad to share that Africa CDC, together with all partners, we managed to have appropriate volume. We need around 6.4 million doses for the next 6 months to vaccinate people in affected countries today. But more important, Africa CDC is working with member states to include the Mpox vaccination into routine and for us to support our countries not to face again this kind of outbreaks we have today. Next slide. Let us talk quickly after Mpox about this illness that we have in DRC. Many people are talking about it, but it comes clear it's mostly malaria based on what we have as lab result. And yes, we believe that there could be other linkages around malaria, but it's no hemorrhagic fever. This one, we are clear. We are not talking about a hemorrhagic fever, but we are just talking about malaria complicated by malnutrition and other issues in the health zone of Basankuso in the northern part of DRC. Next slide. In Uganda, as you know, we still have Mpox and the Ebola outbreak. The good news is for the past 2 weeks, we didn't have any new case. In total, we had 14 cases, 12 confirmed, 2 probable cases. We had 4 deaths, unfortunately, but the good news is we had 10 recoveries. Africa CDC is supporting the country on more holistic way. They got vaccines for Mpox, they got vaccines and other medicines for Ebola, and we are supporting the retrospective investigation mostly for Ebola and to know how it started and how we can avoid that in the future. All of that came after the interaction review that we had a few days ago, and the country is finalizing the 6-month improvement plan that will be integrated one to accelerate the agenda of outbreak response. Next slide. In Angola, last week, we saw a decrease. This week, we saw a slight increase of cases and even deaths. But the good news is, next slide. The good news is the government got, in addition to what Africa CDC provided, you saw my colleague Dr. Ngashi last week in Angola, they got vaccines also from ICG, and we saw more commitment. When I was meeting the president on Friday, he was talking to me like a public health person, and the Minister of Health of Angola was also with him. I think we can see how our leaders in Angola are taking seriously this issue and things are moving. Next slide. This is my last slide. Just to share with you, our first priority today in Africa is to look for appropriate funding. That must be domestic funding, innovative funding, blended finance. Without that, we'll be stuck to respond to all of our outbreaks. In addition to that, we are talking with our partners, like today I'm in Denmark discussing with Bavaria Nordic, and also with our countries to make sure that we don't face vaccine shortage. That one will bring us back on the response that we are providing. We are advocating for security, for more infrastructures, for more funding, for us to increase the testing coverage, because currently we are facing low testing coverage in a number of countries, especially in DRC. Colleagues, let me stop there. I took 30 minutes to brief you on more comprehensive way. My colleagues and myself are available for all of your questions. We can take 1 hour today. It means more than 30 minutes for those who want to ask so many questions. Over to you, Margaret.
Thank you, DG. Let's take the first 2 questions from the chat group. We have Eva from German News Agency. She asks, have you seen a deterioration of Mpox cases in South Kivu and cross-border regions after patients left the treatment centers to join other IDPs in their escape from the fighting? And has it been possible to document their whereabouts until now? And then the second question is from Buguzi of SciDevNet from Tanzania. He asks, has reduced testing capacity of Mpox in DRC increased the threat of cross-border transmission? DJ, you can take those first. Over to you.
Thank you. What's happening in the eastern part of DRC is a major concern. We don't have reliable data and information on exactly what's happening. As you know, we have hundreds and hundreds of people in Goma, in South Kivu, who had to exit the treatment center. And we don't know where they are. They went everywhere. They are not back in the treatment center. Even some of the treatment centers are destroyed. I cannot tell you what is the magnitude of the issue, but I will for sure tell you this one, when we'll have access to data, we'll see a huge increase in terms of Mpox cases, even deaths. And this is really unfortunate. Can we say that the decrease of the low testing rate in DRC is a threat for other countries? Yes, yes, and yes. As we are saying, this decrease on testing rate is mostly in the eastern part of DRC and also other places where we are facing some challenges due to headcount. Because as you know, most of the samples were collected and transported thanks to partners' funds. The combination of insecurity and headcount are exposing other countries because people are moving. Yes, I can confirm, based on the information that we have, it's a major threat for other countries. Back to you.
Thank you, DG. Let's cross over to the floor. We have Sarah Javing from DVEX. You have the floor.
Thank you so much for your presentation, Dr. Kaseya. When you noted in the beginning of your presentation that 2 to 4 million people additionally might die per year, can you explain how is that calculated and what sort of illnesses will be the leading causes of death? And then can you also elaborate on your statements about the continent going 2 decades backward in healthcare, and kind of what do you mean by that, and what programming are you most concerned about? Thank you so much.
Thank you. Let's take the next one before DG comes in. We have Janice from Bloomberg. You have the floor. Janice, if you can hear us. Okay, let's take the next one. Gabriel Emmanuel from NPR, you have the floor.
Hi, thank you very much for doing this. I wanted to actually ask about measles and how things look in Africa if there are outbreaks that are particularly concerning or growing. I'm asking this because members of the WHO mentioned that the global measles and rubella lab network is on the verge of collapse given the cut in US funding. And I wanted to hear how you're seeing the impact of this and kind of where the measles outbreaks are within Africa. Thank you.
Thank you. Over to you, DG.
Colleagues, what we are experiencing in Africa today is dramatic. On Friday, when I had the meeting with all ministers, one of the ministers shared that more than 80% of HIV and malaria services were depending from external assistance. Overnight, everything gone. We have the similar case, even worse, in so many other African countries. What Africa CDC did, we took the mortality and morbidity the drivers of mortality and morbidity in Africa for children, for adolescents, for pregnant women, and for adults. We try to triangulate that with the source of funding to respond to that. As you must know, the first source of funding of health systems in Africa is what we call out-of-pocket. It means people paying to have access to services. That is around 40 to 45% depending on countries. The second source is external funding. That is around 30 to 35% depending on countries. And the last one is the national budget. But when we say health cut, we are not just talking about health sector. We are talking about all other sectors, agriculture, education, social sectors, and all of that. All of these sectors are impacting people in terms of their revenue. This is why we say more than 39 million people will move into poverty. And that one, even I indicated the source because it came from reliable source that we have, that is the UNCTAD. And we also know that when you have World Bank saying that one will also contribute to more poverty, it really means that people who are providing funding to the health system are unable to provide funding. Assistance was mostly going to some of the diseases like malaria, HIV, tuberculosis, maternal and child health. When we did the modeling, we came to that conclusion of the increase of additional 2 to 4 million deaths. But this one can still change if the situation is not managed, appropriately managed. But when we have more deaths, we compare the trend. When it was 2000, how many people were dying in Africa due to illness? And if we see the trend in 2025, we can say it could be similar to what we had in 2000. It means we are reversing the trend of more than 2 decades of effort. This is the simplest way to say that. But if you need all calculations, we are able to provide, my team will provide all calculations to you. And as we say, it will change on a daily basis if nothing is done. Responding to Gabriel, measles is growing. Measles, people are not talking about it a lot. But when we put our data together, like in the eastern part of DRC, we see for children, the main cause of mortality, even if they have other diseases like Mpox, the main cause of mortality remains measles. I think there was a meeting, a press conference where I showed to you the trend, how measles is moving. And we need to protect these children. Measles campaign is not taking place anymore in the eastern part of DRC. And we are expecting to see so many children, unfortunately, dying from this disease. Back to you, Margaret.
Thank you, DG. Let's take the next 2 questions. We have Janice from Bloomberg. Janice, if you can hear us.
Yes, I can hear you. Can you hear me this time?
Yes, we can hear you.
Oh, great. Thank you so much for coming back. Thanks again for this afternoon. My 2 questions were actually around HIV and PEPFAR. Obviously, we know a lot has been halted, but my understanding is that Congress is going to be voting next week on the authorization renewal. And while there are court battles to try and preserve foreign aid, the remaining hope for PEPFAR is now kind of at the mercy of Congress. And, this is a Congress that's already wrangling with a reduced federal budget. I just wanted to confirm if I'd understood that correctly, and if so, what Africa CDC's expectations for that vote is, and what your main concerns are. And my second question was on the same topic, but we're hearing stories about people sort of already trying to spread out their ARVs, maybe taking every third day, that sort of thing. And I was just wondering if you had any particular concerns around people taking those sort of steps in terms of a resistance to something like PrEP, where you can develop a resistance to one of the few options that we have in light of the fact that there's no vaccine for HIV, one of the few preventative options that we have.
Thank you, Janice. Let's take the next one before DG comes in. Kerry Cullinan from Health Policy Watch, you have the floor.
Thank you, Margaret. Mine is also linked to Janice's question. Given that the 25th is when Congress is supposed to be reauthorizing PEPFAR, I just wondered that the DG said he's going to be in Washington next week. So I wondered whether he's going to be meeting anybody in connection with this, and whether he is going to, in addition, be meeting anybody from the Trump administration. And linked to this, the WHO this week said that 6 African countries are on the verge of running out of ARVs. So I wondered whether there would be any emergency help for those countries. Thank you.
Thank you, Kerry. Over to you, DG.
Thank you. The two colleagues, Janice and Kerry, are asking similar questions. They are complementing each other. Then I will just respond directly. Yes, I will be in Washington next week. In my agenda, we had a number of colleagues from the Trump administration and congressmen that I will meet. And we are talking about all of these issues. And I think it will be even time I will be in Washington that will see with congressmen the decision that they will make in terms of PEPFAR and the extension of the program. To be clear on that, we cannot afford to have people under ARVs missing their treatment, because that one is a major risk for themselves, because first, they are developing resistance. Second, there is risk for them to die. And there is also risk to lose, the benefits of ARVs they had, and to start to transmit the disease to other people. I think we know there are countries, more than 6 even, who are at risk for ARV shortage. We want first to discuss with the administration. When I will be back in Africa, I will have a specific meeting with all of these countries linked to the initiative that we have of innovative financing mechanism. We'll not just sit and watch that. We need to act, and we'll act based on what we are doing. Thank you.
Thank you, DG. Let's take the next one from Carmen of Politico. You have the floor.
Thank you so much, Margaret. DG, I wanted to ask you about the U.S. involvement first in your in the plan for health financing that you presented. What role do you see the U.S. having as a donor going forward, if any at all? And the second one, in terms of the responses to the ongoing health emergencies like Mpox, Are you getting any support from the US whatsoever in terms of financing some of the vaccines that were promised, or any other help that you were getting before, you know, the funding freeze and the terminations? Thank you.
Thank you, Carmen. Let's take the next one. Leon from Nation Media Group, you have the floor.
Thank you very much. My question to the DG is about what he has just mentioned about ARV shortages. For a fact, Kenya is very much affected. I've been following, and not just ARVs alone, even TB medication. Kenya used to rely on CHS for testing, collection of samples, and now after USAID was shut down and CHS used to be funded by USAID, I've spoken to health workers who have sputum collections that they cannot take anywhere. They're just with them. I have spoken to someone who has been battling TB for 20 years, and they have to walk kilometers from health facility to health facility. I just wanted to know specifically, when will that meeting be held, and what is being done in connection to Kenya that is currently grappling, especially with the ARV shortage and tuberculosis. Perhaps if you could give me more details and what exactly is the plan that is happening. And then secondly, this is an internal problem. I don't know if Africa CDC is advising the Kenyan government. We recently moved to the Social Health Authority under the new medical insurance scheme. And the problem is that HIV, malaria, and tuberculosis have been classified as pandemics and not as chronic illnesses. Thereby, Kenyans have no insurance cover to even now afford ARVs if they opt to buy them, or treatment for that matter, which is really burdening them in terms of costs. So I don't know if you've had discussions with the Ministry of Health and the Kenyan government, and what are we likely to see? Thank you.
Thank you. DG, over to you.
Thank you, Carmen. My first message to the US government, and I told you, almost 2 weeks and a half, I was in the US, in Washington. First, to discuss with World Bank, to discuss with private sector, to discuss with some of people who can influence the administration decision. My message to them was, we want you to speak the same language as Africa CDC. What it means? It means when you are going to our member state, don't threaten them. Don't tell them that if you increase your budget for health, you are increasing your inflation. No. Encourage them. Let us work together. Let us see how we can join hands to facilitate the process. I got total support from World Bank. Even this is why we are saying we have this meeting during the spring, meeting with all means of finance and some means of health to see on more concrete way how World Bank, IMF can support. US is still a big contributor in all of these mechanisms. If today US can raise the voice to say to World Bank, to IMF, the agenda for Africa CDC is what we need to support, that one will make a huge difference. This is the first one I'm expecting from the US. The second one I'm expecting from the US is the bilateral messages through the ambassadors to clearly say, we are supporting Africa CDC approach. Even this approach was approved by all heads of state. And it's just to send the message to say, we are aligned with Africa CDC. And third, it's to discuss some issues like, as you said, when a government makes a commitment, how can we fulfill this commitment? We had a commitment of 1 million doses for Mpox, $500 million. Yes, around $300 million were disbursed using different channels. We still want to discuss about the $200 million remaining. And we need also to discuss, as I say, the overall vision of the US government after the pause, after closing some programs. How can we work together for all new windows that they have to make sure that what they are doing is supporting our vision? I'm clear, we have a vision. We are not led by partners. We are getting support from partners. With Leon, I will be immediately after the US, I will fly to Côte d'Ivoire. After Côte d'Ivoire, I will fly to Kenya, because Kenya is experiencing a major issue. As you say, HIV, TB, malaria, mostly funded by external partners, were not considered under the health insurance coverage. With what we'll get as result, as you know, when I'm discussing with member states, I'm not doing that through media. I'm doing that through visit, to sit with them, to provide advice, some recommendations. I will be in Kenya. Maybe I will have a live interview with you. My colleague Margaret will be in touch with you, but all of that will be discussed when I will be in Kenya. Over to you, Margaret.
Thank you, DG. Let's take the next two questions. We have Dorcas Wangira from BBC. You have the floor.
So my question is just echoing on from where Leon has left off. Monday is World TB Day. Are there any projections from Africa CDC with regard to TB in terms of the targets that we have this year and in 2030? And then my second question is on the countries that are expecting the Mpox vaccines. I understand Kenya was supposed to have received the vaccines last week, but that has not happened yet. Do we have definite timelines on when these vaccines will be received in country? And then I may have missed the slide on Ebola in Uganda. If you could just probably just repeat on the status of that outbreak, I'd appreciate. Thank you.
Thank you very much. Let's move on to the next question. Kemo from Mano Reporters, you have the floor. Kemo, can you hear us?
Hello, can you hear me?
Yes, we can hear you. Go ahead.
Can you hear us? Yeah, I can hear you. If you can't hear me, it must be my network. I've been struggling. So if you can read the questions that I asked on the forum, I'll be grateful.
Kemo, we can hear you.
Okay, so I'll try. If I fail, then you read, because I'm very much interested in it.
Yeah, I can read the Kemo's questions.
My connection is very bad. I will request you read my question.
Yes, we'll get your question. Thank you.
Yes, Kemo, I see your questions. You are saying in Sierra Leone since January 2025, when the first Mpox case was confirmed, you have now 107 cases with 2 deaths. The last time you checked, officials said none of the cases were linked. The explanation they gave for this is that Mpox has been circulating in the country long before this current outbreak. This called for vaccination, especially for young people. But countries like Sierra Leone haven't prioritized for vaccines for obvious reasons. What Africa CDC could say about it? Kemo, I have my colleagues from IMST leading all of that. I think Dr. Yap and Mosoka, they will respond to this question. They will also respond to the second question from Dorcas on the timeline for Kenya to receive vaccine. But for the first question from Dorcas, yes, Dorcas, we are expecting change on the target for not only TB, not only HIV, for all diseases, even in terms of decrease in terms of mortality. I think this is the simplest way we can respond, because shortage of resources, increase of diseases, yes, target will not be the same. Dr. Yap and colleagues, can you please respond to all other questions?
Thank you, DG. So we have two questions. The first one from Dorcas on the issue of Kenya. There has been some logistical constraints that have delayed the delivery. So the delivery is planned for next week, most likely before the 27th of March. And as Sierra Leone is concerned, it's not a country that has been forgotten. Instead, there is a plan, a conversation ongoing with the country so that the IMST can go and support a visit to ensure that they implement the adequate response. But however, they've already received 58,000 doses of Mpox vaccine, and they are working with Gavi to receive the operation cost so that they can implement their vaccination. Back to you.
Thank you, Dr. Yap. Margaret, back to you.
Thank you very much. Let's get the next two questions. We have Ibrahim from Ghana Star. You have the floor.
Thank you so much, Margaret. I just want to be sure if you can hear me.
Yes, we can hear you. Go ahead.
Okay, thank you very much. Good afternoon, good evening, all. Thank you so much, DG, for the very elaborate brief. My name is Ibrahim Amidu, actually from Nigeria. I have a background in pharmacy, and professionally, I practice as a pharmacovigilance expert. Just not a direct question, but just a comment that even as Africa grapples with emerging diseases and threats like the Mpox and Marburg, strengthening pharmacovigilance systems is critical to ensuring the safety and effectiveness of treatments and vaccines. Real-time data sharing and safety signals will be key to supporting timely regulatory decisions and enhancing public health preparedness across the continent. Thank you very much. Just my comment. Thank you.
Thank you very much. Let's take the next one from Zachary. Zachary, you have the floor, if you can hear us. Zachary, can you hear us? Okay, let's take the next question. We have Joris from Agency France Presse. He asks, how would you say the aid cuts affect or will affect in particular children in Africa? What do you expect in terms of measles, malnutrition, and maybe famine amongst the most vulnerable of the beneficiaries in this case? And then we have the next question from Anate from Reuters. He asks, what are the potential consequences of the US foreign aid cuts and PEPFAR cuts for access to the HIV prevention drug PrEP? And what are the potential consequences of US foreign aid cuts for the malaria vaccine rollout? DG, you can take those two.
First, thank you, Ibrahim, for your comment. We take note of that. You know, when we are talking about aid cut, it's important for us not just to link that to one disease. It's a holistic issue that we are talking about. You see, this money was not just for one disease, was supporting the system. Today, many countries, they don't have access to database on HIV. I don't know if we are talking about it. And we are talking about people who had access to HIV and no one knows. Today, we have a number of countries depending for the human resources on aid cuts. But these human resources were not that dedicated for malaria or HIV. They were dedicated for a number of illnesses. And we can go like that for all pillars of the health system. If we want to analyze, and Africa CDC will share with you a comprehensive analysis of aid cut, my colleague Mosoka, supported by other colleagues, are collecting information country per country for us to come with a comprehensive report that we'll send to our leaders and we'll share with you. It's a disaster. The word is a disaster. Then I will not just respond to malaria, because yes, malaria will be affected, but the whole system will collapse. This is what is too risky for Africa today, to see the whole health systems collapsing. And this is why we are saying we need quickly to find solutions to stop that. And this is what Africa CDC is doing. Back to you, Margaret.
Thank you, DG. Let's take the next question. I have Michael Guarisa from Health Times in Zambia. Michael, if you can hear us, you have the floor.
Okay, thank you so much. I'm from Zimbabwe. So,
Yes.
Dr. Kaseya, you indicated that Mpox vaccine will soon be manufactured in Africa. So I just want to find out, does CDC have timelines as to when this will likely take off? And another question is, you also mentioned that the Mpox vaccine will be included in routine immunization. I just want to find out what is the rollout strategy, which countries and are you going to be targeting first? What's the criteria that you are going to use on that? Thank you and over.
Thank you. DG, over to you. DG, you're on mute.
I'm so sorry. For the very first day, we said the local manufacturing is our key priority in Africa. For the very first day, we started to discuss with Bavaria Nordic. We supported the process. It was a competitive process to identify African manufacturers. We have the outcome. We started now to talk with the successful bidders. Now what we are doing is to finalize some technical issues. Now that I'm talking to you, my team, led by Chanel, Bavarian Nordic team, and African manufacturers, they are meeting. They are meeting to finalize these few technical issues and to make Africa starting to manufacture vaccines in 2025. I wish to tell you next month, but I will not say that because that can take, we are talking about a serious issue that can take a few additional weeks, but be sure we got clear commitment and agreement for that. Some of us who got some vaccinations where we didn't be infected by Mpox. We believe the best way to support our populations and to avoid our countries to start to run when there is outbreak is to have Mpox into routine in Africa. This is the role of Africa CDC. My colleague Landry had a meeting on what we call the Continental Immunization Framework 2-3 days ago in Addis Ababa. We are working to have what we call the life course vaccination in Africa. We are changing the policies in Africa in terms of vaccination schedule. Believe me, we are very serious on that. And we already agreed to have Mpox provided. And my colleagues, Michael, they will provide to you more details in terms of the rollout strategy, countries that will be pilot countries, and how we can scale up that. Thank you.
Thank you, DG. We have a follow-up question from Janice of Bloomberg. She's asking, do you have an expectation that Congress will reauthorize PEPFAR? And will you meet John Kengasong from CDC while in Washington? DG.
I think I don't want to disclose so many things, but I saw high-level meetings that are already organized for me. And I saw that I will meet senior people from CDC and all other agencies. I think if John is still with CDC, there is a huge chance that we meet, but I don't know if he's still with CDC. Over to you.
Thank you, DG. With that, we have come to the end of the briefing today. I'll now hand it over to you, DG, for your closing remarks. Over to you.
Thank you so much to all of you. You can see how busy is Africa CDC time, and I want really to say again, thank you to all of my colleagues. They are heroes. They are doing a lot. And I think when our leaders, they gave to Africa CDC this award, they really know what they are talking about. We will continue to do our best to secure the continent, not only for the innovative and domestic financing, for the local manufacturing, to increase the surveillance and the lab capacity, and will continue to be loud to call for peace and security. It's our mandate to ensure that everything is in place. Those who are in New York and Washington, please contact Director Margaret and try to book some slot. I will be more than happy to meet you and to discuss deeply on our conversation with the Congress, with State Department, with HHS, and with other senior people from the administration. Thank you so much, and see you next time.